Welcome back. It's my pleasure to introduce our next speaker. Wesley Sowers, MD, is a clinical professor of psychiatry at the University of Pittsburgh Medical Center. He comes recommended by our very own symposium medical director, Dr. Cliff Tennyson.
Hello, everybody. Thanks for joining me today. My name is Wes Sowers, and I am the original architect of the Locus family of tools. And we're going to be talking about this new era in value management that Locus and other instruments have introduced. So Locus is the level of care utilization system for psychiatric and addiction services. So first question is, what do we mean by value? And when we're talking about value, it's really the product of quality over cost, and basically how we achieve high quality at the lowest cost possible. And another way of saying that is, how do we get the biggest bang for our buck? And that's really, in many ways, what the Locus family of tools are about. So, as I said, I was the original architect of Locus, and I developed this instrument in conjunction with the American Association for Community Psychiatry almost 25 years ago now. And in the past 25 years, much has happened, and we're going to tell you a little bit about that as we go along. But I wanted first to give you a little bit of background on the developmental history of these instruments, starting in the 1990s. And the context for this was rising costs in healthcare and mental health care, as well as overall health. And there was really questions about the quality of the results we were getting. There was inconsistency in service needs determination, a lack of integration between mental health, physical health, and addiction variables. There was fragmentation in services and discontinuity in care from one level of care to another, and even within provider systems. So part of what happened as a result of this was the emergence of a third party of managed care brought in to really oversee cost and quality control. But as it turned out, at least in the beginning, most of the focus was on cost control. And to do that, various companies who were in charge of the management of value developed medical necessity criteria. And this, in fact, did reduce some of the higher costs that systems were experiencing. And here in this cartoon, the waiter says, "I'll give you a few moments to recover from the prices." And we were indeed having a little bit of trouble recovering from that. So the medical necessity criteria were employed, but there were problems with those and the managed care organizations that developed them. So part of the problem was that these sets were very complex and cumbersome, so they were kind of difficult to access. They were inflexible and program specific. And they had a limited relationship to treatment planning. It was more of a cookie cutter approach, or one size fits all. It's either you fit in or you didn't. So it's sort of a binary kind of arrangement. They were difficult to access, so there was little transparency, and there were so many different sets from different companies that it was very difficult for providers to stay on top of the criteria being used. And this created a lot of administrative waste. And so there was this micromanagement of utilization and much time spent on reviewing decisions about the intensity of service. This created kind of an adversarial relationship because of the conflicting interests of the providers and consumers in many cases, and the managed care companies. And so this was not a great design overall. And this hit pretty hard in Tennessee. My good friend Cliff Tennyson, who I have served on the board of the AACP with for several years, used to tell these horror stories of what happened in Tennessee as they transitioned to public sector managed care in the 1990s. There was a lack of oversight and accountability. There was extreme cost cutting to maximize profit, and the quality of care really deteriorated for many folks with severe mental illness. And let me see if I can get that. So one of the things that I was the chief medical officer for the Center for Addiction Services at a large provider organization, and really struggling with some of these problems with medical necessity criteria. And one of the things that I had exposure to was the early versions of the American Society of Addiction Medicine's criteria for addiction services. And these were something that we were using. And I thought, well, maybe we need something like this for mental health, and particularly for co-occurring disorders. And so began to think about what is rational care management. So what we wanted to achieve is a balance of quality and resource use. So we were using our resources wisely to get good results, and that any system should be outcome driven, both in terms of healthy individuals and healthy communities. There should be a complete continuum of care and individual planning so that we can really tailor services to the needs of a client. Integrated care and resource management in one set of hands rather than kind of the adversarial arrangement that had evolved. And that we had universal standards or a common language for talking about needs. The other piece, obviously, is administrative simplicity and eliminating some of the waste that was associated with the micromanagement that I discussed earlier. And here the spokesperson says, to answer your question, we may or may not be trying to have it both ways. And in fact, that is exactly what Locus and its derivatives are trying to do, to have both low cost and effective services. So back in the mid 1990s, I began to do an extensive review of existing tools. I mentioned the ASAM criteria, but there were also a large number of proprietary tools. And so, began to think about how to take advantage of the best qualities of all these tools. And one of the things that emerged was a dimensional assessment tool that is quantifiable and interactive, that there be a unique resource continuum with flexible levels of service intensity. And what we ended up with is a description that was characterized by 4 variables and very adaptable. I'm sorry, let me go back to that. And by 2016, 20 years after it was first released, it's been used in various settings across the US and Canada. We've established reliability and validity, and Locus 20 was the 3rd version. And we have ongoing review and field testing in place. The criteria has been remarkably resilient and has pretty much remained in its original form since it was released in 1996. So that kind of gives us some sense of the validity of the criteria that were developed. And there's been a digital version available since 1998. So I say we because, as I said, we developed this instrument in conjunction with the AACP, and we had the input from a committee on our board that kind of reviewed the tool as it was built and gave valuable input. So what is Locus? As I said, developed by the AACP, and it's a tool that supports individualized service and systems planning. So it provides a system for assessment of service needs for adult clients based on 6 evaluation parameters or dimensions. It defines 6 levels of care based on the amount and scope of resources available. And it quantifies service needs through ratings to derive recommendations for service intensity. So in addition to Locus, the adult tool, in 2001, CA Locus, or Child and Adolescent Locus, was released. And there is a third tool called the Early Childhood Service Intensity Instrument that was released in 2019. CA Locus was derived directly from Locus and developed in partnership with the American Academy of Child and Adolescent Psychiatry. Children and adolescents 6 to 18 years old were the target population. And it has the same structure and placement algorithm as Locus, and develops the systems of care from a systems of care perspective. The Early Childhood Service Intensity Instrument, or EXI, was developed by the American Academy for infants and children less than 6 years old. It follows the same principles as the parent tools, but it has a slightly different structure and placement process. So when we look at traditional medical necessity criteria, we're just going to contrast this with Locus. So these are initiated by a request for approval. There are criteria sets to determine eligibility for a requested service or intervention that are defined in advance. So it does not provide a clinical assessment of needs, and it does not incorporate quantifiable dimensional ratings. There's a separate set of criteria for admissions, continuing stay, and discharge. And these tools typically don't inform treatment planning. They're predetermined service sets. And these may include criteria for specific procedures, such as ECT, or in other cases, diagnostic pathways like inpatient care for psychosis. So by contrast, the Locus tools start with an assessment of service intensity needs and not the request for specific services. Service planning is guided by the Locus assessment and creates an individualized profile of issues that must be addressed. There are quantifiable dimensional ratings that allow interaction and facilitate communication, that kind of standard language. And there's one set of criteria used for admission, continuing stay, and transition. So it simplifies the process considerably. It's accessible, transparent, it's quick and easy to use, and it facilitates recovery-oriented care. And these can be done, again, with participation by service users. And so it encourages partnerships between payers, providers, and service users. That I'm sorry about this. That was not previously available in the antagonistic relationship that existed between MCOs and providers. And there are advantages for Locus for payers as well. It reduces review processes, so there's more resources for treatment, creates a common language for monitoring patient progress, facilitates partnerships with providers. So again, collaborative versus adversarial, and it's not diagnostically dependent. So we say it's transdiagnostic. It looks at function rather than a specific label. Population data can facilitate bundled rate setting, and we'll talk about this a little bit more, but it allows partial to full delegation of risk to providers. And it informs the allocation of resources for network development. So again, looking at these partnerships, these tools are best used jointly by payers and providers, and then they can work together for the best outcomes. There's client participation in assessment and planning, and so they're more invested in the outcome. There's clinical autonomy and involvement in cost consciousness of recommendations on the provider end, and so they have more control over their services and outcomes. And MCOs can concentrate on care coordination and quality monitoring rather than cost in particular. So all the entities are able to be involved in this process. And I'm sorry about the problem with the slides. There's a sharing of risk and objectives. And so there's much more likelihood of collaboration, investment, satisfaction, and integrity of the tools. And the other thing is that it provides continuity through transitions, and these assessments can be carried and recorded through acute episodes and consider long-term needs. So here we have the waitress. She says, do you want the check all for one or one for all? And the answer is yes. So why is there so much interest in this now? This is driven in part by a court case, Witt versus United Behavioral Health. And the basic issue is with the decisions from United Behavioral Health was, what processes led to decision about which services were approved, and were those processes and the decision in these cases more restrictive than generally accepted standards of care? And this led to a basic question: what are generally accepted standards of care? And so in the case, the judges issued a very sophisticated decision and outlined 8 principles of generally accepted standards of care. And we're going to go through those. But first, I just want to review a little bit what the court took issue with in terms of UBH's guidelines. They were found to be inconsistent with generally accepted standards of care. There was an excessive emphasis on addressing acute symptoms and stabilizing crisis while ignoring longer-term needs. And they favored less restrictive placements over more effective interventions. So they failed to adopt a separate level of care criteria unique to the needs of children and adolescents. They deviated from the generally accepted standards of care by imposing mandatory prerequisites like diagnosis. And UBH's guidelines instructed clients or clinicians to collect a wide array of information, but they didn't really allow adequate consideration of that information in the rules and requirements that govern coverage for determinations. So UBH breached its duty as fiduciary. It violated state laws in some cases. And the guidelines were fundamentally flawed because the process was tainted by UBH's financial interests. So what were the 8 standards of care stipulated by Witt versus UBH? So the first is effective treatment requires treatment of the underlying condition and not limited to the alleviation of current symptoms. Effective treatment requires integrated care of co-occurring behavioral health and or medical or addiction issues. 3 was the fact that a lower level of care is less restrictive or intensive, doesn't justify selecting it if it is less effective than more intensive and restrictive services. Number 4, when there's ambiguity as to the appropriate level of care, the practitioner should err on the side of caution by placing the patient at a higher level of care. Number 5, effective treatment includes services needed to maintain functioning or prevent deterioration. And you have to keep treatment in place if it is needed to prevent relapse or deterioration. Number 6, the appropriate duration of treatment is based on the individual needs of the client, and not there should be no specific limit on the duration of the treatment. Number 7, the unique needs of children and adolescents have to be taken into account. And number 8, the determination of an appropriate level of care for patients should be made on the basis of a multidimensional assessment that takes into account a wide variety of information about the patient. So they also outline some specific sources of generally accepted standards of care. And obviously, Locus and CA Locus were mentioned, and actually many of these 8 principles of standards were derived from Locus. Also, the American Society of Addiction Medicine criteria, the ASAM criteria. There are also some practice guidelines developed by organizations like the American Psychiatric Association and the American Academy of Child and Adolescent Psychiatry. So, why should we choose Locus? It meets the court's definition of accepted standards of care, and as I said, many of those were derived from Locus. Efficient scoring and placement recommendations, reducing waste in the system, facilitates recovery-oriented care and patient-directed care. It creates uniformity and consistency in the decision-making process, and that reduces bias and discrimination in some of the products of structural kinds of discrimination that many systems have in place. And it has a variety of value management functions, which we're going to also be talking about a little bit later on in the presentation. So in this cartoon, it says, first I did things for my parents' approval, then I did things for my parents' disapproval, and now I don't know why I do things. And so part of the value of Locus is that it helps us be clear about why we're doing what we're doing. So the Locus family of tools promote a common language among all stakeholders, and that includes people served, providers, payers, and even the public is part of the idea that we need to be able to be clear about how we talk about these decisions. So now I'm going to be telling you a little bit about the structure of, excuse me, the structure of Locus, adult Locus. Many of these things that we're going to discuss apply to the child version, CA Locus as well, and to a large degree to EXI and the entire family of the Locus tools. So first, we're going to look at the dimensions of care that are used to create these ratings. In each of the 6 dimensions, there's a 5-point scale. There's a criteria set for each numeric point in this scale. There's basically 2 to 5 descriptors attached to each numeric point. The rater selects the highest rating in each dimension in which at least one of the criteria is met. And if no criteria is exact, we select the closest fit. When uncertain, we choose the higher rating, and dimensional scores are summed to obtain a composite score. And this is just a quick look at the determination grid. You can see on the left-hand side the dimensions, which we're going to go over individually, and across the top, the various levels of care. And in the grid, there are scoring parameters basically that lead to scoring, and across the bottom there you can see the composite rating. So we're going to go into this in more detail, so don't worry. First part of that is to look at the 6 dimensions and what they contain. And these are the 6 dimensions of assessment. So in each of these dimensions, there's an opening paragraph explaining the important aspects of choosing the most appropriate rating. Users should become familiar with all the information contained in that introduction and can refer back to them when needed in the scoring process. And so this is too small for you to actually read, but this just kind of gives you an idea of the length and breadth of these introductory paragraphs that really outline the significant points of how we choose the proper rating, and if there are any caveats or particular things that raters need to be aware of as they go through each dimension. So first of all, we're going to take a look at dimension 1, which is risk of harm, and that looks at issues like suicide, homicide, awareness of danger. It looks at various risk factors like current ideation, intention, planning, level of distress, history of behaviors, suicidal behaviors or homicidal behaviors, impulsivity, whether people act without thinking. Intoxication can sometimes have a role in harming, self-harm as well. We assess changes from baseline in certain circumstances. People have suffer with chronic thoughts about suicide, and what we are most concerned about in those cases are changes from that baseline. Aggression and non-lethal self-injury are actually rated on the next dimension, functional status. And so we're mostly looking at things that put people at pretty high risk of acute, potentially lethal activity or harm. So one thing that's stands out in this dimension and the next 2 dimension is that high scores override composite scores. So, at the end, we add up, all the ratings in each of the dimensions, and that gives us a composite score, which guides us to a level of care. But if somebody scores very high in this dimension, and, they have suicide thoughts, for example, it doesn't matter what the scores are in the other dimension. You want to get that person in, a secure level of care. So we'll talk about this a little bit more as we go along. This is just to give you an idea of what these criteria sets look like. So these are the first 3 numeric ratings. And as you can see, there's minimal, low risk, moderate risk of harm. And in each one of those numeric ratings, there are letter descriptors of particular thought patterns or behaviors. And so raters are instructed to select one or more of those descriptors. And in the case, as I said before, where if the risk or the descriptor chosen in 4 fits, but there's also one of the descriptors in 5 that fits, we would choose 5. So this is just to give a little bit of an idea of how the dimensional ratings look and how raters are guided in their choice of the most appropriate description of what's going on in their client and in the assessment. And often, as I said, the person that's being evaluated can participate in this process. The language has intentionally been made simple enough that most people are able to follow it. So the next dimension is functional status, and there's 4 factors: whether people can fulfill obligations, the quality of their interpersonal interactions, vegetative or physical changes such as sleep, weight, appetite, those kinds of things, and also their ability to care for themselves. We only rate disabilities due to behavioral health disorders. Physical health incapacities are rated on the following dimension. And again, here we compare against baseline. You know, everybody functions at a little bit different level, and we're most concerned about deviations from that level. Again, here in this dimension, high scores override composite scores. So here the gentleman says, I'm slowly weaning myself off of employment. And, you know, this is often one of the things that we look at in terms of function, whether we're able to continue with our normal activities. So dimension 3 is comorbidity, and we look at mental health, physical health, and addictions. We identify a presenting condition, basically the chief complaint, and rate the impact of any other conditions that they may have. Physiologic withdrawal is considered a physical health condition for those people with substance use problems. And here, once again, high scores override composite scores. So somebody presents with a mental health complaint, and it turns out that they also have significant addictions. Those two really interact, and the presence of the addiction makes concern about mental health and recovery greater. Moving on to dimension 4, recovery environment. This really has 2 scales, and so it brings the number of ratings to 7 when we complete an assessment. It has 2 scales, stress and support. And these elements interact to create an overall estimate of environmental impact. We look at both professional and natural supports. And we pay special attention here to transitions. When somebody is being transitioned from a protected or highly supportive environment, we make a rating that's based on a forecast of their likely circumstances that they will encounter once they're in the community, or whatever other new circumstance they encounter. And so this is really to ensure adequate planning for transition and making sure that people are well situated as they transition to between levels of care. So as I said, there is a scale for stress. And so we look at interpersonal disruptions that may be stressful, physical disruptions in their with their body and their physical state. We look at safety and how much that may play a role, and transitions. When we think about supports, we look at natural supports, professional supports, their ability to access supports that are available and willingness to do so, and again, whether they can engage with supports that are potentially in their for their benefit. Okay, and so moving on, dimension 5, treatment and recovery history. In this dimension, we're looking at past responses to treatment and ability to maintain recovery over time. We weigh recent experiences more heavily than those in the distant past. And this is especially pertinent to treatment planning as we want to avoid repeating past failures and give people the best chance to do well. Dimension 6 is engagement and recovery factors. And this again looks at 4 factors: understanding and recognition of their condition, their desire and readiness for change, ability to use various sources of assistance, and to accept responsibility for change. These ratings are correlated to Prochaska and de Clementi's stages of change. And, this is intuitive that lower ratings, or when people are easily engaged, they will require fewer external resources. So this gentleman says, this is where I get most of my negative thinking done. So again, when people are stuck in sort of a negative way of thinking and about their ability to make change, it really creates impediments to successful services. So now we're going to move on and consider the 6 levels of care. And these are defined across the top of the placement grid that we showed you earlier. So just to distinguish these from the traditional paradigms in which eligibility criteria were created for a predetermined service set, locus levels of resource intensity are defined by 4 variables: care environment, clinical services, support services, and crisis and prevention services. Each locality derives a menu of elements per variable at each level of care. And some elements may be available at more than one level of care. That we can think of things like supported housing or case management. The average cost is proportional to the service intensity. So the higher service intensities, the higher levels of care, like inpatient type services, are obviously more expensive than community-based services. And so what they do is really provide an ideal and seamless continuum of service care, service elements. So the receptionist says here, he's away attending to a personal matter, but he did leave a number where he can't be reached. And so, access is obviously a big issue, and something that we want to be thinking about in terms of the levels of care and their definition. So one way to think about the way that Locus thinks about service intensity levels is to think about what we do when we go to a restaurant. And so first we decide what we need, right? And that's similar to the level of care assessment. How hungry are you? What kind of dietary restrictions? Are there any digestive disabilities? These things all sort of determine what we need when we're looking for a restaurant. And we also need to figure out where we are and what is available within our area. And so those are first 2 elements. And then when we think about it, we want to, what is the environment that we want to be in? Is it indoor versus outdoor, fancy versus rustic? And these are basically analogous to the environmental variable in our definitions of level of care. What kind of food type, quality and quantity? Those would be analogous to clinical services. Do we want table services versus pickup? And that would be analogous to what kinds of support. And in this era of COVID, are there masks, social distance? Is there good ventilation? And these are all related to the prevention, or analogous to the prevention variables in Locus. So before we get to the actually defined levels, there's basic services that all communities should provide. And this is sometimes referred to as level 0. But in any case, these are services that are related to prevention and health maintenance. They should be available to everyone, not dependent on the rating. And these include emergency and crisis services and community health and prevention focused um, types of interventions, outreach to homeless folks, disaster first aid, screening, and include things like education, consultation, and support. Um, so here is a stepwise look at the 6 levels of care in Locus, and the top upper part there, you can see 6 is the most intense and 1 is the least intense, and we're going to start there. Level 1 is recovery maintenance and health management. And it's a transition to independence for people who have progressed in their recovery. It's a step down service, not an entry level of care. And it is related to things like medication management and recovery maintenance therapy. And these folks usually don't require a great deal of support. So level 2 is low intensity community-based services, and the traditional analog is outpatient treatment. Um, it's an entry level of care and usually provided in a clinic setting. There may be education and employment assistance, but generally there's a limited range of support services that are needed. Next up the ladder is high intensity community-based services, and the traditional clinical analog is intensive outpatient. These are non-restricted facilities with a full array of treatment and service elements, and there are more frequent and extended contacts. Supports may include service coordination, supported housing, and rehabilitation activities. Level 4 is medically monitored non-residential services. This is partial hospital or intensive wraparound with a full array of treatment and interventions. Could be something like an ACT team. So in this level, people generally receive daily attention, usually scheduled and structured at least 5 days a week. There are frequent psychiatric contacts and availability, and there's a prominent role for service coordination, housing, and rehabilitation. Level 5, medically monitored residential services. And these include residential treatment programs, respite facilities, drug and alcohol rehabilitation programs. They're not secure, they're not locked, but they are highly structured settings. Psychiatric contacts usually occur weekly, at least. There's a full array of services available, and this is team-based care. Again, transition planning and addressing significant disabilities and barriers to community living are really essential at this level. And finally, level 6 is medically managed residential services. The traditional clinical analog is acute or long-term inpatient treatment. These are secure settings that are highly structured with restricted access. Usually daily psychiatric contact and close monitoring. Crisis intervention and de-escalation are available within the facility. There's a full array of treatment options and team-based care and intensive transition planning. So these are fairly intense kinds of services, and again, secure. They may be in the community, a small long-term residential secure facility would fit the bill in this case. So, we've talked about the ratings and we've talked about the level of care. So, how do we move from one to the other? And that's what we're going to talk about next. Um, so, this service intensity recommendations are derived from the dimensional rating scores, and they range from 7 to 35. We took a look at the grid, but there's also a flow chart with a decision tree or algorithm for translating the scores into a recommendation. And that system has been computerized, as I said, and has been available for a number of years. So the composite scores do correspond to the recommendations in most cases, but there are independent criteria that we talked about when ratings of 4 or 5 are made on one of the first 3 dimensions. So that eh, makes the transition or the translation process a little simpler in some cases. This is just a sample of the printout or the report that's generated by the computerized version of Locus. It records all the scores over here in each one of the dimension, as well as the descriptor in each of the dimensions that corresponds or that created eligibility for the selection. So this conveniently summarizes the work that has been done. So I'm going to just go real quickly and tell you about the residential sublevels of care. So there are 5 sublevels defined, 2 in level 6 and 3 in level 5. 6A is high intensity acute medically managed residential treatment program. And so these are pretty much, as we described, highly structured, secure settings, analogous to inpatient programs in most cases, but a little bit more flexible. Frequent contacts, full range of treatment options. The length of stay is usually less than 7 days. It may be a little bit more in some cases. And usually after that, there's a step down to 5A. 6B is medically managed extended care residential treatment program. And these are for individuals that cannot be stabilized within a brief period of time. And they may have continued volatility or potentially dangerous or dysfunctional behaviors. And we see this is more analogous to a state hospital or community-based long-term secure residence. The average length of stay can be months, and these folks might be transitioned to either 5B or 5C, which we'll talk about in a minute. And these are community-based or intensive wraparound services. 5A is intensive short-term residential treatment programs, often, as I said, a step down from 6A, sometimes called subacute or respite services. Intensive treatment and in transition planning take place, frequent psychiatric visits and availability, and usual transition takes place within 7 to 14 days. So these are relatively short term, and a variety of dispositions may be appropriate for the transition. Moderate intensity intermediate stay, RTP. This is for people requiring rehabilitation and skill or resilience building prior to community transition. There is intensive treatment and psychiatric attention. Substance use rehabilitation is commonly fits within this category. And as I said, it may be a step down from 6A. The average length of stay is between 15 and 30 days and usually does not exceed 60. Moderate intensity long-term residential treatment programs are for people with severe impairments, and they require extensive rehabilitation and skill building to transition to the community. And these may include nursing facilities or long-term rehabs, There's a full array of services and frequent psychiatric attention and a variable length of stay. It could be 2 months, it could be up to a year. So those are basically a description of the level of care. I'm just going to move on now to summarize a little bit what we've been talking about in terms of locus and its qualities. So these dimensional ratings are simple, they're relevant, and they show change. They're dynamic over time. They're quantifiable ratings, and that promotes interactivity of the dimensions, communication, and the placement process. They integrate all emotional health criteria, so they're diagnostically independent, and they consider interaction between illness categories. Some of the qualities of locus: they're easy to use and understand. We talked about that. Accessible, intuitive structure. They facilitate person-centered care and empowerment. They are computer friendly and easy to use in that regard. We have established reliability and validity, informs individualized treatment planning, and it's a collaborative assessment with the person being assessed. And here the doctor says, would you say it's more of a burning or a stabbing pain? And again, the interaction between provider and the person being assessed is really important in this regard. So there are some other pieces that supplement locus. There's a training manual that contains a semi-structured interview, a pre and post test. There are practice cases, worksheets that can be used. The residential sublevels that I described are included in the training manual. There is an appendix on guidelines for meeting primary care needs. And there's also an automated treatment planner, which I'm going to tell you a little about if we have some time. So what will locus not do? Well, it doesn't prescribe program design. That's left to providers. It doesn't specify treatment interventions. Once again, the treatment plan is something that is developed by the provider and the person in services. So it doesn't replace clinical judgment. It just ensures that it is applied in a more consistent and fair way. So it doesn't limit creativity. It just kind of gives us a framework to think about, to think through problems and needs. So there's a variety of extended uses for locus. We talked about this idea of dimensional service planning. So depending on which dimensions indicate the greatest need, we can focus on those in the service plan. It provides a rationale. It creates an explanation for why we're making the decisions we make. And that is useful in utilization review processes as long as they exist. The collaboration we mentioned between provider and managed care organization. So one of the things is that this is an opportunity for risk sharing and the delegation of value management to one entity that considers both. And so it reduces administration and redistributes resources. It's a platform for integrated service documentation from the evaluation through progress documentation, through transition planning, and carries over to the next levels of care so that there's a continuous updating of accomplishment and also regression, that we can monitor the course of the illness and resource use for individual. It can be used to track outcomes. We haven't validated it for this purpose, but it tracks not only the progression of somebody through the levels of care, but also tracks the use of resources over time. And it's also useful for systems planning. It identifies deficits in the service array. So we talked about local menus containing the various elements of the plan, of the variables that we described. And if services are not available at a particular level of care, that will be clear. And people need to be placed at a higher level of care if there's a deficit in that regard. So that will help us identify those deficits and create services. In terms of financing, it can assist in bundled rate setting. And that's a little bit more complex, but is another very useful thing when we think of downloading responsibility to providers and keeping resource management in one set of hands. So here again is a look at the evaluation report, just to kind of point out how we can then look at the scores that are highest, like in medical, addictive, and comorbidity, environment, treatment and recovery history. And these are the things that we would be most likely to address in the treatment plan. So I'm going to just spend a little bit of time talking about dissemination and implementation. So historically, there's been slow but steady uptake over the first 20 years. There has been significant use in 25 states and 5 Canadian provinces, and some international use as well. But a lot of times that usage has been fragmentary, in other words, not across the entire continuum. And a lot of the pieces of continuity from one service to the next was lost because of this. So it might be just used for crisis services or to determine whether residential services are needed. There has been mixed paper and digital use, and it's been primarily by providers. We have had open access, which has been good in terms of exposure, but there's been difficulty monitoring appropriate use. And that has been a bit of a problem. So for the most part, the training that has been done has been live and on site, and hasn't been necessarily required, just encouraged. And there have been limited research opportunities past the original studies that were done. But things have been changing a little bit. In 2017, the National Council really clearly endorsed Locus, and the National Council is an organization of providers of behavioral health services. So that was a little bit of a boost. With the WIT decision against UBH has spurred a lot of development. Several states have mandates for managed care organizations now, both public and private, to use professionally developed criteria. So this has been the case in California, New York, Oregon, Illinois, and there's actually several other states now that are requiring the use of Locus or similar kinds of instruments to govern service intensity decisions. There's been the formation of a Locus advisory group that includes the National Council and a number of stakeholders from various parts of the country. And there has been an expansion of some training options. But there's been some challenges. We really would like a more balanced penetration of payers and providers. They should be using these instruments in concert with each other. So that's been a little bit difficult getting to. Access versus quality control. So Again, we want this to be widely available, but we also want to be able to ensure that it's being used properly and across the continuum. Uh, we have been trying to develop training, various training opportunities so that there are options. But again, this is an issue of time and expense, and so that has been challenging. We would like to get to registration and certification of users. Um, we are operating pretty much on a voluntary basis, and so these processes do require a good deal of time. And so that has been challenging to free up the time needed to develop these things. We would like to have better data collection and expand our data on reliability and validity. So all those things are in process, and we're trying to meet those challenges by getting users registered. We are trying to develop some live in addition to the in-person or online trainings. So this is a recorded or asynchronous training option. We would like to do competency testing and have a certification process that we can really easily establish some inter-rater reliability testing on an ongoing basis. And so that needs to include significant data collection and working with users to get that data entered. So finally, this caption reads, perhaps your performance anxiety wouldn't be so bad if you perform better. And in fact, that is what Locus family of tools are trying to get us to do, is to perform a little bit better and manage our resources accordingly. I was going to try to say a little bit about the next generation, or how we get from assessment to planning. I think we have a minute or two to do that. Basically, the Locus Empower Planner is the multidimensional person-oriented wellness, empowerment, and recovery planner. And that acronym was, in fact, a challenge in itself. But it's based on and integrated with the level of care with the Locus as it was developed by the AACP. And it translates the issues identified in Locus assessment to an electronic planning process, which is designed as a collaborative, consumer-directed, computer-assisted planning process. So I'm going to just kind of go through these slides quickly in the interest of time. The Empower Plan development identifies priorities, change categories. It's assisted by the Locus report, and it's related to the level of care. It guides us through the choice of intermediate and short-term goals, and is organized similarly to what many treatment plans do in terms of identifying objectives and methods and so on. And does this through a series of menus that can be performed with the person being assessed. We took a look at the Locus evaluation report earlier, and so the treatment planner works directly from this. And what you can see down at the bottom is an assessment summary, which is constructed from the descriptors that were selected, and can be edited by the clinician and the client. And up here on top, it shows the categories that need to be addressed. It has a entry point for additions to the narrative summary. It defines an overall goal. It can include advanced directives. and also a personal recovery plan. It has an extensive menu of strengths in each dimension. And eventually then for each selected dimension, it offers, again, a variety of choices that can be selected to address various things that are identified in the plan. It then allows us to look at specific interventions and the people that are responsible for those things. In the end, it creates a report of the treatment plan, very much similar to what many treatment plans look like. But again, this is facilitated and really individualized through the process of the electronic translation, and really allows the consumer to participate in that process. So we're back to performance, and I would like to thank you for sticking with me. I know that this was a very long presentation, and I hope I kept your interest, and certainly looking forward to any questions that you might have. So thanks again, and good luck with the Locus family of tools.
So here we are. I hope people were able to hang in for that. These are long presentations, but certainly would be interested to hear any reactions that you have, and certainly happy to tell you a little bit more about Locus and how it can be used in a way that really facilitates practice and good decisions about meeting people's needs. Cliff, it looks like you're muted.
Now, okay. Hopefully I can be heard. I'll keep my eye on the question and answer chat form over here, but I went ahead and took the liberty to jot down about 6 different questions that I have. So why don't I start there, and then I'll keep watching for these questions to appear over here. The first several are really easy, and they might seem almost too elementary. But the first question is, did payers actually become interested in this? Did they actually believe that the tool could save or better spend their money? I mean, you were talking about payer-provider collaboration and coordination. And when you used that term, my eyebrows went up. So I wonder about that.
Yeah, you know, it is kind of strange because we have, I think, in the past 20 years become so accustomed to thinking of this as sort of a tug of war rather than a partnership. And, you know, it's a good question, Cliff, because there really has been, I think, reluctance and slow recognition that this actually has advantages for payers, who, especially for-profit organizations, who are kind of looking to satisfy their stockholders' needs for, you know, kind of profits in the short term. And so, it's been more difficult, I think, for those companies to really take a longer view and to understand that, they're actually going to be better off if they, incorporate these practices. And, if they allow providers to work with their clients to make decisions that are ultimately going to reduce their need for services. And so, I think one of the barriers to that has sometimes been the transitory nature of covered lives. And, if a provider, if a payer, doesn't see their membership as sort of long-term membership, if they think that they, may not be with them for the long haul, then prevention isn't as attractive. And so, that's one of the things that really came out in the WIT decision, that these decisions have to consider longer term needs. And so we had some managed care organizations that recognized this, prior to the WIT decision, but that and other developments have really spurred many payer organizations to take a different look at this. And I think as they've done that, they've come to understand a little bit better that it's actually in their interest to do so. And Optum, or a subsidiary of UBH, that has about 40 million covered lives in behavioral health, has really taken this up and has went forward with it, and has really recognized that it is in their interests in the long run to eliminate a lot of the administrative waste that goes into these extensive reviews of clinical decisions.
Thanks. Well, I have another one. You talked about training. You said it's not required, but it's recommended. And one of your future things is to look into registration and even certification, that people have been trained to be able to use the tool. I particularly like the restaurant analogy. Thought that was good.
I was wondering if that would work out for people.
Yeah. But okay, so the question is, since you answered the certification, training, registration question already, what's it like? In person, virtual? How intense is it? How often? Is it daily for a week? Is it once a week for 2 months? How is it usually done?
It's really been evolving. I think I mentioned, that for many years it was really in-person training, pretty much. I mean, we had a training manual, which, kind of pretty extensively laid out the nuances of scoring and use of the instrument, and had several exercises and opportunities to practice scoring. Those things were done in the in-person training, but that was curtailed quite a bit with increased demand, which was really just difficult to keep up with somebody traveling from site to site. And also the restrictions of COVID and, the need to develop virtual interactions for training opportunities. So there have been a number of permutations of training. One of the things that I have always maintained is that, Locus is pretty intuitive. And unlike some instruments, doesn't probably require the intensity of training that is often needed for more complex systems. And, you know, if you just kind of read through it and follow the instructions, you know, you can stay pretty much on target. But there are nuances, and there is a matter of familiarity that people gain when they have experience. And so as we develop sort of a recorded training, we're kind of thinking of that as consisting of basic training to get the nuts and bolts down, sort a little bit like part of what we went through this afternoon. Another section would be the recorded interview with a client and how information is elicited and how Locus can be completed with the participation of the person being assessed. And then, you know, how we work with clients to derive a recommendation. So the last 3 parts of the training would then be just going over sample cases, and in an interactive format that sometimes is available on platforms like Zoom. We can survey participants and see how they've rated and explain, you know, the rationale for the most appropriate selection. So, you know, there's, again, just a range of ways of doing this. What we want to do is make sure that everybody is equipped to, you know, use the tool as it's intended.
Yeah. Yeah, I was also going to ask you about the relationship of the locus assessment to ongoing treatment planning. I mean, once the level of care has been determined, is it appropriate to use some of this data or all of the data? And you explained that. You said you're looking into that, you're developing that as we speak, and to develop a treatment planning instrument. So thank you for that. So
I think, you know, one of the things that I would just say, Cliff, is that, you know, often people kind of think of these tools as being a burden, or, you know, sort of an extra layer of what they have to do in order to meet the requirements of their organization or the state or whatever the case might be. You know, one of the things that was primary in the development of Locus was the facilitation of clinical processes. And if used, I think as it was intended and designed, I think this really facilitates these clinical processes. It guides our assessment process. When we are gathering the information with Locus in mind, it really becomes a very rapid process to actually do the ratings and come up with a recommendation. It then provides a framework for progress documentation as we go along, and for treatment planning. As I said, you know, it kind of helps us focus on and prioritize the most immediate needs and where we need to look in our plan with clients. And so, as I said, you know, it provides a framework for progress documentation and transition planning. And as we do progressive encounters with clients, we don't really have to repeat the whole instrument, because some of it is not going to change acutely, but we can just focus on those areas in the treatment plan that we're targeting. And it may be that just one-dimensional score will change, or two-dimensional scores will change. And so it really doesn't add a significant amount of time to the clinical processes that we engage in, and really helps integrate them and clarify our processes.
Have any users used it or wanted to use it to address issues of medically ill, mentally ill persons? Does it help with transferring care? Does it help with in integrated care settings that are more than just, you know, collaborative, cooperative care? We have a social worker down the hall in the family practice office, but I mean, really integrated care settings.
Yeah, and you know what I think I just mentioned briefly, there's an appendix in the most recent version of Locus that is concerned with the most appropriate level of primary care and collaboration based on Locus criteria.
Okay.
And you know, one of the things that is unique, I think, at least in the way that it's organized with Locus, is the incorporation of considering the interaction of medical illness and also substance use with psychiatric symptoms.
Yeah.
And so, you know, that's one of the most significant issues, I think, when we were looking at the genesis and the sustenance of psychiatric symptoms. You know, these things have tremendous impact, and when they do have impact, we obviously may want to ramp up the intensity of services that we provide to meet the needs that result.
Has there been much uptake, and I imagine the answer is yes, but I'll ask, by some other real specific organizations that do primarily IOP and residential for personality disorders or for eating disorders or for intellectual disability services?
You know, I think one thing that's interesting and perhaps misunderstood a little bit about Locus is this whole idea of being transdiagnostic or not diagnostically dependent. So, you know, we have these subpopulations which it's not specifically designed for, but it's not really specifically designed for any population. And what it does is it really looks at functional dimensions of our behavior to make determinations about what our needs are. So, you know, in terms of eating disorders, obviously, people who are anorexic, for example, may have real problems in terms of their risk of harming themselves. You know, when it comes to that, when their physical function is so debilitated because of their withholding of food, that's a significant risk. It's also causes problems with their functioning, right? That they're not able to, you know, kind of fulfill their responsibilities and do the things that they need to do. It also creates medical problems, which on the third dimension kind of figures into our assessment. So we can think about that. We can think about it with geriatric populations who may be demented and unable to make good judgments and so on. So it has, I think, application that fits pretty well with most of the subpopulations that we can imagine.
Yeah, I wanted you to hit again on the transdiagnostic capability of the tool, because that was in one of the very first slides a long time ago. So,
Yeah.
okay, well, we're going to have to close to let the attendees go do other things for the next 15 minutes. Thank you very much, Wes Sowers. I appreciate it. Appreciate your being here and sharing this with us.
My pleasure. Thank you. Thank you all for your patience and hanging in there, and hope this was helpful.